Hello everyone, my name is Mike Hartung. I'm an abdominal radiologist from the University of Wisconsin, and I will be presenting some ideas on how to create a great radiology report. I'd like to start with acknowledging the collaborative nature of this material. I am greatly appreciative of my wonderful co-authors who have helped me refine the ideas presented here. This talk is complementary with and expands on the radiographics paper of the same name, which was published in the fall of 2020. We are going to start with what might seem to be a detour, but I promise is foundational to getting better at reporting. Let's take a moment to consider this question. How do you develop expertise and excellence as a radiologist? We all end training with some basic level of competency that allows us to safely practice radiology, but we are a long way from having true expertise at that point. How do you bridge that gap? And of course, for those of us who are already in practice, there is another enemy looming in the shadows. That is, the threat of loss of skill over time. And even worse, to have this occur but not even be aware of it. So how can we keep our skills sharp after we improve them? Our world is obsessed with the idea of innate talent and IQ as the special sauce for success. And we can easily assume that the major differentiating factor for success in our field are those who have the biggest brains. But take a moment and think about someone you really admire as a radiologist. Think about what they do, how they practice, and their habits. Do you really think that's the secret to their success? Sure, they are smart, probably really smart, but we are all smart enough to become epic radiologists. Many of these epic radiologists care about the patients a lot. And that caring manifests as one of the most potent expertise developing tools around. That is, FollowUp. Epic radiologists follow up their patients. FollowUp provides endless opportunities for feedback, education, and improvement, but there are some hurdles for us to overcome. The nature of our specialty allows us to isolate ourselves from the true clinical impact of our reporting, often creating physical and communication barriers between the ordering providers and the patients. As a consequence, we can become more interested in being radiology right than clinically relevant. But follow-up keeps us anchored in the clinical reality of the patient. It makes clinical knowledge and experience sticky, giving us memorable educational stories that we carry for years. It is the major contributor to deliberate practice, which has been described in the expertise literature as the major building block for becoming a true expert. Features of deliberate practice include an intentional, focused review for the purposes of receiving feedback and improving performance. The QR code links out to a nice summary of the ideas in this book and a Harvard Business Review article if the concept of deliberate practice is new to you. The final potent element of follow-up is that it engages our emotion at a level that typical case reading does not. In many ways, it is an act of caring for and about the patient and the ordering providers whose actions are influenced heavily by what we report. I believe this emotional engagement is a major reason that cases we follow up become so memorable. When you engage in follow-up, the patient and entire healthcare system essentially become your teachers. You get the glory of finding out you were right, but also the lumps that come with realizing your assessment was incorrect. You will have opportunities for targeted, contextual learning, which is the most memorable kind. Your heart will expand with connectedness and empathy towards the patient and ordering providers. But as I mentioned, feedback can be painful. Nobody wants to find out they are wrong or could have done something better. That is hard, and I encourage you to find a peaceful and professional way of putting this pain in a proper place. You are not following up cases to find reasons for self-loathing and flagellation, but rather to grow as a professional and to help patients. Keep the goal in mind and give yourself grace, as you will invariably wrestle with cases that you could have done better on. Here are some ideas when to follow up cases. MyPax has a built-in follow-up feature, and I know others that use a secure spreadsheet or something similar. And specifically for trainees, you should become obsessive about following up cases during training. And don't forget to shoot your attending a quick note about your extra efforts and what you learned, as that is sure to impress them and build up trust. Perhaps all that talk about follow-up was a surprising start to a talk about radiology reporting. So how does this all connect? In many ways, follow-up should be legally listed as a co-author for any talk or paper on reporting. Our reports result in a variety of clinical actions, and those clinical actions will ultimately lead to patient outcomes. When we follow up our cases and seek feedback, we turn back to our reporting to look for ways to improve the accuracy and contents of our reports. In other words, our reporting cannot help but improve if you engage in this essential feedback and improvement cycle. All right, we are now ready to move on to some specific reporting principles and tips. And I don't want to lose anyone on our first point of disagreement, so please remember that these are general ideas and principles, but not rules. We all have our own personal and institutional preferences, and at the end of the day, this talk will be a resounding victory if I get you to simply think more critically about your own reports on a daily basis. Success in reporting does mean a willingness to discard your pet phrases or confusing terms in our radiology lexicon that you might hold dear for the sake of clear communication. So please keep an open mind. In much of our reporting, we can convey more information with greater clarity using fewer words. A good deal of the words that we include in our reports largely amounts to filler or fluff. So while there may be some stylistic reasons to include some of the terms, much of what we say can be distilled into an essence, and that essence promotes clear communication. In this example, the first impression contains a natural sentence structure that, despite conveying simple ideas, is difficult to wrap your head around and requires translation to apply the information clinically. Many of these words are unnecessary as they obscure clinically meaningful information. The revised impression is straightforward and easy to understand and apply clinically. While such a terse report might surprise you at first glance, the reality is that there is no reason to surround our clear ideas with unnecessary fillers that cloud their meaning. Let's consider another example. This similarly long impression contains unnatural sentence structure, but such language is not unusual in radiology reporting. It can be edited and distilled into a shorter impression that now includes additional helpful information to create a more accurate mental representation of this patient's adrenal mass for the reader. Our reports should be memorable and easy to digest and not require translation. Think about physicians reading them out loud during morning rounds or to a patient in an office visit. State your findings and impression in a direct manner. Don't shy away from simplicity of language for fear that it might appear unsophisticated. And finally, clear, direct language can be easily translated into action by the ordering provider. The radiology report has a massive audience, and such an audience can pull us in many different directions. But in this talk, we are mostly going to focus on our communication with the ordering provider, because they asked for the exam, they get the results, and they are responsible for acting on them. Our priority is to deliver a clear assessment of the patient's imaging findings with specific recommendations to the ordering provider. Not only do we have to balance the diverse audience of the radiology report, but there are other elements about the nature of our specialty that make reporting difficult. It is important to acknowledge these, sympathize with each other, and try to understand how they impact our reporting. Most specialties don't have to be right away. They interact with patients over a timeline where they can modify or adjust their assessment based on the changing clinical parameters or new clinical information. We are uniquely put in the position of making a final assessment based on imaging findings in a single point of time, often with little clinical or laboratory information. Our mistakes are publicly documented and easy to point out. This creates stress and insecurity about our reporting. These stressors on reporting bias us towards avoiding synthesis, using non-committal wording, giving vague or overly aggressive recommendations for follow-up, and shifting responsibility back to the ordering provider for unknown or uncertain findings. So this must be a new problem, right? Well, not according to the radiologist Dr. Enfield, who wrote on this topic about 100 years ago and described the makings of a bad radiology report. He talks about a radiologist describing in detail all that they see, but not telling what they think about it. Such a report tells much, yet almost nothing. The tendency to restate findings and avoid clinical synthesis and application is not a new problem in radiology, and is one that will continue to impact our specialty. And that makes sense because we're talking about different level tasks here. Reporting findings is largely an observational skill that even junior trainees can become competent at. And indeed, I expect residents to make most important findings after their first rotation or two, but I don't necessarily expect them to know what they mean or what to do with them. That brings us to the impression, where we sort out the meaning of the findings. Synthesizing the findings into a clinically meaningful assessment and communicating a clear, accurate impression is the highest level task of the radiologist, and one that matures later in training and continues to grow and refine in practice. The findings can be thought of as a complete, accurate radiological description of all abnormalities along with relevant normal observations. The stylistic emphasis in the findings is on short, informative, and descriptive phrases. The impression is defined as the meaning of the findings, which is presented as a diagnosis or differential diagnosis, along with recommendations for further management. You can think of these as what is seen with the eyes and what matters to the brain. It is time to get practical with a tune-up and some ideas for improving the contents of your reports. I will now address the findings and impressions separately and focus on a few high-yield areas. We can divide our tune-up into stylistic and content areas, and under style for the findings, we will focus on avoiding terms of perception and redundancy. Radiologists tend to overuse terms of perception. It is very natural for us to use them because by nature we are talking about what we see when dictating the report. However, terms of perception are largely unnecessary except for stylistic and readability reasons. Our perception is assumed as we read the study, look at images, and describe what we see, and it risks diluting the meaningful information with linguistic fluff as we ramble on with unnaturally prolonged sentences. Challenge yourself by counting them sometime in your own reports, and you'll likely be as surprised and motivated to slim things down as I was. The second stylistic area for tune-up is to avoid redundancy, which actually has a lot in common with what we just covered, as terms of perception often quickly pile on to make reports redundant. But another major culprit for redundancy which contributes to unnatural sentences revolves around making comparisons, and you'll notice that we really tend to pile these on in our reports. I think the major reason for this is that many of us dictate reports as we are actively thinking, and that unavoidably will create redundancy. In this first example, you can imagine the radiologist first seeing the masses, talking about them, then pulling down the comparison study and making an assessment about the change over time. Simplifying the findings in this way does require withholding comment into the dictaphone until you have a little more to say than that you see something, and this can be challenging to do. But I hope you can appreciate the difference this makes for simplicity and clarity. It's hard to believe that these short phrases have just as much information as the longer sentences that they have replaced, but it is true. So, when you're making a comparison, more does not make merrier. Just pick one and move on. That wraps up style. We are now ready to move on to content, which will include withholding interpretation for the impression and how to handle incidental findings. Regarding interpretation, we commonly blur the lines between the findings section and the impression by repeating partial or complete impression statements in both sections. It is natural to begin to process and synthesize the findings while reporting them, but the problem is that this creates unnecessarily long, repetitive reports with an increased risk of internal discrepancies, as changes or revisions need to be made in both the findings and the impression. You can start the process By building an implied differential by stating pertinent positive and negative findings without necessarily synthesizing them into a diagnosis. And these findings should not require revision even if you decide to tweak your impression. Embedding synthesis in your findings can be particularly problematic for trainees because the busy attending radiologists often focus on correcting the impression rather than revising the findings. It is best to keep it clean and avoid interpreting the findings. As we consider our handling of incidental findings, let's share a moment of solidarity regarding frustrations from unnecessary follow-up and apparent confusion about what matters in a radiology study. But we must ask ourselves, why is this happening and what can we do to improve it? I believe a major part of this falls back on us for being non-committal and not providing a clear assessment of something as benign and requiring no further follow-up. And so there is an important exception to withholding interpretation in the findings section, and that is for so-called buried findings that you do not intend to discuss in the impression. There is nothing terribly wrong with the following examples, except that a non-radiologist will likely not know what to do with them, and this can generate patient anxiety, as many internet searches for incidental findings on radiology studies will mention the possibility of cancer even though we do not find them suspicious at all. So if you think something is benign, do everyone a favor and just say so by calling it benign or of no clinical significance. But there is a reflexive objection to this. How can we be 100% sure that a finding is benign? And I can certainly sympathize with that. The assumption here is that ambiguity somehow is helpful or provides legal protection, but in reality, it does not. We have a responsibility to make a clear assessment of our studies, including recommendations. You need to decide if something can be let go or if something needs to be done. While this might feel uncomfortable at first, making an assessment gets you out of the vague, ambiguous, non-committal middle ground, which essentially shifts responsibility onto the lap of the ordering provider to figure out what to do with an incidental finding, even though they don't have expertise in radiological interpretation. The great part about doing this is that it promotes radiologic competence for all parties and will help teach other providers about what matters most in our studies. As we wrap up our slides on the findings, let's consider how advice changes with experience. For those of you training junior residents, you should not be trying to make clones, and I think it is a mistake to encourage them to have reports that are ultra brief. Early in training, we should encourage their language and even ramblings to flourish in the findings. They will develop their vocabulary through practice. Without this essential step, they will lack the depth of vocabulary to accurately characterize complex pathology. Don't expect them to reach your level of brevity and clarity from the start. That takes a lot of time, rambling, and pruning with experience. Let's take a moment to talk about structured reporting. I imagine many of you use structured reports, possibly with mixed feelings about them. Structured reporting is a double-edged sword, and I personally have decided to fall on the blade because I think it provides the best balance for a predictable report in a training environment, at least for abdominal CT. But structured reports must be thoughtfully designed and implemented. One of the first questions you face is what to do with those blanks. Should you leave them empty or pre-populated? And pre-populated with what? The word normal or a full sentence? The best answer is ultimately a compromise and will depend on the complexity of your practice and if you are training residents. Self-reflection is needed when implementing structured reporting. Ask yourself, am I engaged? Are my neurons firing? Or am I mindlessly tabbing through fields and making minor edits to the pre-filled normal language? Does starting with a normal, essentially signable report bias my review and decrease my engagement with the study? Our practice is an academic referral center which trains residents and fellows and used free text or narrative reporting for abdominal CTs until only a few years ago. We adopted a completely blank structure for abdominal CT templates to avoid any bias and, quite frankly, the inconvenience that pre-populated normal text would have for our complex patient population. We also believe that blank fields are best for trainees as they develop their language and reporting skills. All right, we are now ready to wrap up the findings, and can summarize the goals of that section as follows. As you describe the findings, start to build an implied differential diagnosis based on your description and language, but without stating a specific diagnosis outright. And for trainees, unless you missed something, you should have the goal that your findings section should not require much, if any, correction after staffing. Now we are ready to tackle the impression. Similarly here, we will look for ways to improve both the style and the content of the impression. For style, we will discuss avoiding technical language and leading with the favored diagnosis. Avoiding technical language may seem like an easy, straightforward thing to do, but it can actually be quite challenging. That is because technical language is on your mind as you just wrapped up dictating the findings section. But the impression is a communication to non-radiologists, and they are not trained in technical radiology terms, and spoiler alert, they are not interested in them either. The biggest offender is signal characteristics, often from MRI and ultrasound, and rambling on about these features leads to a risk of misunderstanding the impression. For these two examples, we remove the MRI and ultrasound characteristics to clearly state what we are concerned about, including recommendations where appropriate. Something that I find particularly helpful is to try to state the impression in a similar way that I would when speaking on the phone with the ordering provider or presenting in a multidisciplinary conference. In these settings, I find it easier to cut to the chase and state things clearly and succinctly as possible, and that is precisely the sort of language we should be using in our impressions. This second stylistic tune-up point makes such a huge difference, and that is to lead with the diagnosis. A way to think of it is stating what you think is going on as quickly as possible, rather than building up to it like a punchline or arguing your way to its inevitability by piling on a list of findings. Remember, you have already supported your diagnosis in the findings section and you don't have to do it again. Looking at both of these examples, these straightforward diagnoses have a risk of getting lost in the lengthy surrounding details. Instead, cut to the chase and say what you think is going on up front. The reason why this makes such a huge difference is that impressions that start by jumping into detailed findings are likely to overwhelm the reader with seemingly stray facts with little provided basis for understanding them until a specific diagnosis is mentioned. When you lead with a diagnosis or favorite diagnosis, you anchor the impression and provide a context for the reader in which the relevant findings can be properly understood. You're basically saying, here's what we might be dealing with, and then you're filling in the important details that follow. That wraps up style. Now on to content, where we will discuss the importance of avoiding clinically insignificant observations and making clear recommendations. It can be challenging to know what to include in the impression and what to leave in the findings, particularly during training. But I think we've all come across unhelpful shopping list impressions that detail nearly every passing observation that the radiologist makes. In this case, it is easy to overlook the fact that there is an ovarian mass that needs to be worked up, as you are lulled to sleep by this rambling list. Aside from diluting the important diagnoses, these types of impressions also create unnecessary patient anxiety and trigger inappropriate follow-up examinations that we talked about earlier. I think the conflict of what to include and what to omit can be approached in a simple way. If you don't want the ordering provider to think about it or act on it, don't include it in the impression. Remember, they are busy and mostly interested in actionable findings. Our final area of impression tune-up focuses on recommendations, and this brings together a lot of important concepts. Recommendations are a major way that radiologists take responsibility for a study and advanced patient care. So consider, nobody will have greater insight into the study than you have. Nobody will take more time to interpret the study than you have taken. And you ultimately have the responsibility to provide a complete evaluation and clear recommendations. There are some key questions that can help guide the formation of the recommendations, and what it really boils down to is giving as specific or direct advice as possible. One might object to this and say that specialists are offended with direct recommendations, and certainly that might be true in some institutions where they prefer just to have the facts. But at the end of the day, these experts are free to ignore your advice and do what they think is best, and if you follow up on cases, you will also become much better at giving appropriate advice that aligns with their typical management. On the other hand, not giving clear recommendations carries a much greater risk for harm and confusion, and in general, providers are very appreciative of you helping them to know what are the right next steps. A major benefit to providing clear recommendations is that it helps to circumvent the inherent ambiguity of the terminology that we apply to convey various degrees of diagnostic certainty. This kappa graph from a radiology reporting paper shows just how miserably radiologists and non-radiologists agree on terminology surrounding certainty. Anything above 0.7 indicates agreement, and anything below 0.4 indicates disagreement about the meaning of the phrases. And thus, basically the only phrase we agree on is the significance of diagnostic of, and everything else had low agreement on the scale. Even phrases like consistent with, highly suggestive of, most likely, and compatible with. I encourage you to find your favorite phrases in this chart and let the burn of our lack of mutual understanding motivate you to find ways to bridge this gap. People have attempted to create certainty scales where they assign percentages of diagnostic certainty to different phrases, and that very well might be a helpful exercise in some cases. But I also want to emphasize that our recommendations give weight to how serious we think something is, and are a major way that we can modulate the perception surrounding our levels of certainty for a diagnosis. To close our discussion on the impression, I want to propose some strategies for tackling tough, puzzling cases in a confident and helpful way. You can consider this approach as a 4-step process. It starts with anchoring your impression by stating a favored diagnosis or category of disease. Then, take a few sentences and summarize the key findings so you can create a proper mental image of the scan for the ordering provider. Now, we'll get into the nuance and mention other possible diagnoses and how seriously they should be considered. And finally, we'll move towards action and resolution by giving helpful recommendations. Let's consider some examples. In this first case, let's imagine that we see a large liver mass and we're pretty sure it's malignant, so we'll start with that, followed by a brief explanation of what exactly we're seeing. In this case, the imaging features favor a primary liver tumor, and let's say they only did a portal venous phase study, so we're stuck between hepatocellular carcinoma or cholangiocarcinoma. Well, that makes our recommendations easy enough. The next best step is to get an MRI, and if they're still unsure after that, they can recommend a biopsy. In this example, we're going to start with a disease category, and you'll see why this is so helpful. This ED patient is presenting with a large bowel obstruction caused by a stricture in the sigmoid colon. This is a great anchor statement. Notice how we have given the category of the disease and the cause, a stricture, without trying to swing for the fence about the specifics. From here, the ED provider clearly knows what's going on and can explain it simply to the patient, family, and the admitting team. Now, we'll create a word picture and explain what we see and why it's somewhat equivocal as to the cause. Next, we'll give a differential diagnosis for this colonic stricture with some additional helpful comments. And finally, we are thinking practically about management and diagnosis. It's time to consider decompressing the colon and also taking a biopsy. I want to point out something important here. No matter what happens with the final diagnosis, in this case, our first line of the impression will remain 100% correct because we emphasized true, broad, categorical statements about the disease rather than trying to be correct about all of the granular details. You have anchored this patient's care and future treatment, keeping all teams on the same page as they move forward in reaching a definitive diagnosis. Let's wrap up with some departing principles to help guide you on your way. Learning to report is not like learning a fact. Learning to report is not a box that you check during training. Reporting is a continual work in progress that will require your careful attention throughout your career. And finally, we can think of this as a sort of golden rule in radiology, where we try to create the sort of thoughtful, thorough, and responsible reports that you would want for the care of a close friend, family member, or even for yourself. And with that, I thank you so much for your attention, and I hope you found this presentation helpful and inspiring for your own reporting.